Hello, my name is Desiree Beck, and I have prepared a slideshow regarding bilingual families and multi-generational homes. In this presentation, I will address the following diversity and family factors: bilingual families, multi-generational homes, with the pros and cons of a large family home, and how race plays a part in getting treatment. I will discuss cultural competence, language barriers, how other cultures accept the diagnosis of autism, stereotypes in bilingual communities, guidelines to follow, and how to work with families. What is cultural competence? That's a great place to start in knowing what this term means as a practitioner. It is simple yet complex. It is having the knowledge and skills that are needed to address language and culture, along with continual learning. Dalrymple and Johnson, 2019. So just meaning to keep up with what's going on in the field and continuing education to make sure that you're on point with what's going on and what treatments best fit your clients. Not every client has the same need. Race and ethnicity are two major factors that contribute to how an individual receives care and resources that are available. Here, I have broken down some things from two specific communities of individuals. Some of these topics that are addressed overlap into each of these communities. Let's touch on a few that are similar in both communities to get a better picture at how these individuals are not receiving the proper resources. So first, the Black communities and the Hispanic communities are what I chose because I am a biracial child. So I kind of see both sides of this. So I also wanted to incorporate what I know into this. So late diagnoses in both communities, it tends to happen between ages 2.5 to 4, which is outside of the early intervention stage, where they can start getting diagnoses at 18 months. Let's see. The lack of access to services. Not all communities have access to services. If you think about Hispanic families, the stereotype is that most of them are migrant workers, so they may just be here for a certain part of the year, working on farms and then going back to their home countries. So they may not know where to start or to get services, or they're scared because they may not be here on a work visa. There's a lot of things that come into play there. And in the Black communities, the issues of mental health are always brought up. That they struggle with mental health issues naturally, or they have misdiagnoses, and it's very hard to be comfortable to go to the doctor and knowing that you feel this way and that you just feel that you're not being treated fairly. And the big one that really had hit hard for me was, like I said, the mental health issues that were brought up, and that these people would rather die before getting treatment due to the feeling that they are not heard as individuals, or they do not matter. Language barriers that go deeper than speaking a different language. The materials that are given out of information about autism spectrum disorder are not properly translated from English to another language, so that can cause confusion and concerns that some may not know how to address. So that's the things about race and ethnicity that I kind of touched on to draw a bigger picture to what's happening as far as individuals getting treatment when it comes to autism. Bilingual families is a broad category. There are many households that have a dual language that are spoken. Let's take a look at what I mean by that statement. When a child who has a diagnosis, or any child for that matter, may struggle with knowing what language to use in what environment, the biggest concern of bilingual families is what should the primary primary language be that is spoken in the home? Do families speak their native language and speak English as a secondary outside of the home? And do they speak English as a primary language because that is what society expects? Or even being just in the United States, it's expected that we all know English. There is a drawback to speaking two languages, and that is how it will affect children who have a language impairment and other developmental disabilities. When looking at this from a practitioner standpoint, I would go with the primary language that is spoken at home. That's the language that the child most likely is to hear. Yes, they may be getting services in a facility where everybody speaks primarily English, but I do think that it's okay if a child is not fluent in English, if that's their first language is Spanish or Arabic, or something that's not English. It's possible to get practitioners who are bilingual as well to help with this gap with language barriers and treatment with our children who have a diagnosis, to show that we are culturally competent and receptive to what's going on in the world. Let's see. Learning English, incorporating English into treatment planning to individualize treatments, and not just hearing that primary language at home, but they would be able to incorporate learning English into their treatment planning, but also can still speak their primary language. There are several different stereotypes in the bilingual community that affect the way to get effective services. One that was already discussed is the language barrier. Attitudes are sometimes seen as passive, meaning that parents or caregivers seem very laxed about what is really going on due to not having the information or knowing signs of what to possibly see, when to possibly seek professional opinion about what is going on with their child. In some of these communities, the services are limited and scarce. So not having reliable and accessible treatment does make a difference with these children. And they may have stereotypes on the medical system when it comes to getting their child treated. Are they going to be discriminated because they're a different culture or a different race? Are their beliefs going to be taken into consideration when thinking about treatment and what's there for them to get treatment, and the different ways that as a community things could be provided? And they're not sure where to start to get assistance. So I think there needs to be more out there for families to have more accessibility, especially in bilingual communities and in Hispanic and Black and other cultures and communities, to make sure that they're getting the access that they need for their children to go above and beyond and soar. In a multi-generational home, there are several pros and cons. So let's take a look at the chart below. So the pros in a multi-generational home, there's a set routine. There's always somebody going to be there to help this child when one person is not available. If mom is not available, it could be grandma, it could be an aunt or an uncle or grandpa. They have multiple helping hands, so they're not getting burnout. They have more opportunities for social interactions, which we know that social interaction and social skills are a deficit with children who have autism. So this allows for more social interactions, and they have great rapport with their caregivers because they know them. They've probably been around them since birth. Some of the drawbacks or downfalls of being in a multi-generational home with a child with autism is sensory overload. We know that a lot of these children have issues with sensory things, it being too loud, not being able to process, constant movements. And so this particular picture Here is a little boy sitting at the table screaming with his ears covered because he is having some kind of sensory overload, and this is how he's reacting, to calm himself and for those to hear and see him. There's competition for attention if there's other family members and children in the picture. The child who has autism may not be getting the attention that they need, or or may want, because they're not sure how to ask for attention. So there may be lacks of that in bonding. The needs are not being met. This is not uncommon. If some family members are not sure how to meet the needs, then they may not know. They may not think to ask, is this something that I need to take care of? How do we do it? They may not be on the same page when it comes to how to run the routine or what's expected, and they may have unrealistic expectations of this child because their other children are neurotypical and don't have these different quirks and things that we know that autistic children have, such as stimming and their stereotypy. That may not look normal in their family, and so it may be something hard to grasp. But there are a lot of pros and cons to a multi-generational home. In different cultures, there are several things to think about when it comes to acceptance of a diagnosis. What we see as a symptom of autism and a behavioral issue, other cultures may not see it the same. What is acceptable in one culture may not be acceptable in another. Several other aspects play a part in acceptance, such as their religion, the age and gender of their children or the parents, and the socioeconomic status are just a few. There are lots of things to think about when we think about a diagnosis and how different cultures and communities accept these things. What is their outlook on disabilities in their community? Is it frowned upon? Is it looked as a weakness? There's several things as far as their religion. Do they not believe in medical treatment? Do they believe that all children and people are created in the way that God wants them to be, so they don't want to get treatment even though it will benefit that child? So there's a lot of aspects that we have to keep in mind as practitioners to make sure that we are giving our children and families the proper care that they need. As a practitioner, we need to make sure that we are being respectful to our clients and stakeholders, showing compassion and kindness, building rapport with the families and including them on the treatment plans and decisions, to make sure that these things are culturally acceptable. Meaning, don't leave mom and dad in the dark about the treatments that are going on. Have parent meetings quarterly so that they can see the progress, or if you have suggestions about maybe we can do this at home, as this is what we're doing here, and kind of get on the same page to make sure that these children are getting everything that they need. And most of all, treating all clients and stakeholders with equity, not equality. There are several ways to make sure that as practitioners we are giving our all to our clients. First and foremost, we must have a self-evaluation of our own culture, ethnicity, and background. So here are 3 simple steps to take before really getting into services with families. First, we must have self-knowledge. Knowledge of other cultures to provide excellent services, and lastly, knowledge of practice. How do you stay culturally aware? What can be changed in how to clinically shift interactions and bridge the gaps of cultural differences? These are all things to think about as a practitioner, to examine yourself, to make sure that you're staying culturally aware, culturally competent, making sure that you are educating yourself on not only your culture but other cultures, and allowing these families to get the treatment that they need and not putting them in an uncomfortable place because you're not sure if it's culturally acceptable. When I first came across this image, it spoke volumes to me. In the first picture, you see equality, meaning everyone benefits from the same support and guidance, which is not true. Treatment for anybody, think about your family, your husband, your child, and yourself. You may not need the same kind of care if you're sick. So healthcare and any kind of care and treatment and services are not cookie cutter. It's not about equality. Whereas in the second picture, you see equity and all the individuals at the same height to see over the fence. Equity is giving individualized support to all meeting their specific needs. So in the first picture, we can compare the first and second picture, which amazes me, that, I think most people have a mindset of equality, where you have a gentleman who's tall enough who doesn't need to be over the fence and standing on a box, where you have the little girl who could see a little higher if she had both boxes. So that's where the equity comes in the second picture. And the little boy in the wheelchair, he can't see anything but a fence. And if you give him the needs and resources he needs, he gets a ramp to be able to see the soccer game. So now all of their needs are being met, and they're able to participate in the same activities and enjoy different activities in life together, and not feel that they are not getting their needs met. So also, when working with families, treatment plans should be individualized. No treatment plan is cookie cutter for any child. Every child has different skills, different learning deficits, different skill deficits. So we really have to go through different steps to make sure that we are prioritizing each client or stakeholder to make sure that they're getting the individualized treatment that they need. So here there is an 8-step individualized treatment plan kind of layout of where to start and where to go, and what that may look like as a practitioner and in your clinic. And here is the resources and references that I found to give you the information about this presentation. I hope that this was knowledgeable and helps you with these different topics and how to stay culturally competent and aware. Thank you for watching, and I hope that you enjoyed.